We're going to get started. Good morning, everybody. And thank you for coming bright and early. It's always a pleasure to host Grand Round speakers. We often host them from all over the world, but we always have to remember that there's world-class talent here. Today is no exception. It is my absolute privilege to introduce my friend and colleague, Dr. Cho, who all of us know. She wears many hats. Louis Vuitton, she wears many hats. She's the vice chair for HVTI. She's section head for preventive cardiology. She's director of Women's Health Center. She's also a professor of medicine. She's from California. If many of you may or may not know, she did her undergrad at UCLA, then moved eastward to Chicago for med school, residency in Washington State, and then came to Cleveland for her general and interventional cardiology fellowship. Had a couple of years when she went back to Chicago, and then she's been here since 2005 as section head of preventive medicine, cardiology, and as we've known, she's done really, really, really well. She is a world authority on preventive cardiology and women's health disease, especially as it relates to cardiology. And for the trainees, you have to, a lot of things you may or may not realize, okay? Long before lipoprotein A was fashionable and everybody and their grandmother was, running trials in lipoprotein A, Dr. Cho had the vision to set up every patient that walked into preventive clinic got lipoprotein A measured. This was long before it was fashionable, and I think we sit on the world's largest lipoprotein A repository. So a lot of good things have come out of it and will come out of it. But today, it is her job to teach us about the rapidly evolving field of dyslipidemia. Lots of new guidelines, lots of new stuff coming out. So she's going to tell us what are the top 10 take-home messages from the guidelines. Leslie, thank you.
Well, thank you so much. It's really my pleasure to be here with you this morning. I'm especially thrilled to have Dr. Durasti, who trained me, sitting in the front row and center. Yay, Dr. Durasti. So when I was a fellow, and there are fellows sitting over here, and I was doing cardiac cath, and we used to watch films on the Tijerno, not on, Cine, on the computer. He would always tell me, we're gonna go look at some dirty films. We're gonna go look at some dirty pictures. You remember this? Yes, and then this was when I didn't even know my diagonal from my LAD, and Dr. Durasti was kind enough to show me all of that. So it's really my pleasure and a thrill to be here with you this morning to talk about the ACC-AHA guidelines for dyslipidemia, which I was privileged to be part of. So let's just dive right in. So I'm gonna ask the fellows over here, when was the earliest time that you got your lipids checked? We'll start with Ryan Searcy. Ryan, when was the first time you got your lipids checked? 16. Wow, okay, that's amazing. Because the number one, can I go forward? Oh, there we go. The number one message, really, truly the number one message for the lipid guidelines is to start early, to check your cholesterol early, to reduce lifetime exposure to LDL. And so this guidance is very different from the 2018 guidelines. And what you can tell already from the 2018 to 2026 guideline is that there was this notion about age 40 that no longer applies. So all adults, heterozygous FH, should be started on statin. If you're age greater than 30, regardless of your heterozygosity or whatever, if your LDL is greater than 160, or you have a strong family history, or you have a high 30-year risk, you should be starting statin therapy. And really, time is key. Early intervention reduces lifetime risk for atherosclerosis. And there is very good data that the risk increases as average non-HDL increases starting at 125. So your non-HDL is total cholesterol minus your HDL. At greater than 125, that risk really starts to increase. But you can't treat it if you don't look for it. So screen early. So screening at age greater than 2 if you have family history of premature ASCVD or heterozygous FH or homozygous FH. And this actually received a lot of controversy because there was all this stuff about, oh, they want to start statins in a 2-year-old. That's not the point. The point is to identify people with heterozygous FH because that actually happens in 1 in 250 patients. You screen for everybody else starting at age 9 to 11. This is not just the guidance of the ACC AHA, but it's been the guidance for the American College of Pediatrics for over a decade. So this is actually something not new. It may have been new to the public, but it's actually not new. And then you start screening at age 19, and you get screening every 5 years thereafter, or every year thereafter if you have some other special risk factor. You aim for a lower LDL throughout your mid-age. So ideally, if there was peace in the Middle East, peace in Ukraine, your LDL should be 100 if you have no disease. Ideally, less than 70 if you have atherosclerosis without risk. And if you have high risk, then less than 55. And then you treat for longer. You know, this idea of stopping treatment at age 75 or age 80, we all know 75 is the new 60 if you look at Dr. Durasti. Or, you know, so that treatment longer and with the benefit increasing. And of course, when do you check? We'll go through all of that in a second. So the second big thing to come out is the updated risk based on a new calculator. So we all know the pool cohort equation, but of course, the latest calculator is the Prevent ASCVD. And there's a lot of controversy, and I'm gonna go through that with you in a second. You're gonna do the calculator if the 10-year risk between the ages of 30 to 79, but if you're younger, God bless, 30-year ASCVD risk between the ages of 30 to 59. We all know that the pool cohort equation overestimated the 10-year risk, and I'll show you by how much in a second. And the Prevent ASCVD risk is generally lower than the pool cohort equation. So let's just talk about the development and validation of the Prevent risk equation. So the data source is 6.6 million cohorts using the EMR database. And really, it's similar with the prior risk model with adjudicated outcomes, but they added few more things like social determinants of health, like renal dysfunction and things like this. Broad racial and ethnic diversity. So that's non-Hispanic white, non-Hispanic Black, Hispanic. The only cohort that's really truly underrepresented, again, unfortunately, are the Hispanics and the Asians. They're underrepresented in the population. So the new Prevent equation encompasses the social determinants of health, as well as the traditional things like age and blood pressure and cholesterol and medication use and diabetes, but also non-traditional things like eGFR and urine albumin creatinine, hemoglobin A1C. So this is the new Prevent ASCVD, and I hope to have this actually in our Epic so that you can just click on it and it'll pop up instead of you putting all this nuanced things in there. 25 data set, 3 million patients. Validation is 21 data set with another 3 million patients. It's sex specific, 10 to 30-year risk estimate adjusted for competing risk. And the outcomes are CVD, ASCVD, plus heart failure, which I think is very novel. And it's a very, very good predictor. So you can see that between females and males, ASCVD and heart failure, you can see the events and the C statistics. So you can see how, so higher the C statistics, better it is. So 0.5 is a coin toss. So as you go up, it's a much, much better predictor. And of course, calibration slope, 1 is perfect. Around there is what we're aiming for. And you can see that it's a fairly good predictor for CVD, ASCVD, and for heart failure. Now, we can talk about heart failure in a second with the males, but for the most part, it's excellent. The calibration slopes by race, you can see Asians versus Black adults, Hispanic adults, and white adults. And you can see the whites are much better because there's a much bigger cohort. Hispanic adults, but the worst one is probably Asians, right? Because much smaller population. But let's compare it to the pool cohort equation. This pool cohort equation, which has, when it was initially released with the 2018 guideline, received a lot of criticism for being an overestimate. Indeed, it doesn't estimate very well. But compared to Prevent ASCVD, you can see the vast improvement with the new equation. With Asians and Black adults, Hispanics, and especially with whites. You can see from 0.52, that's the calibration slope, to the white adults of 1. And it's consistent across the US. So this is looking at various cohort data. Many people say Rancho Bernardo data is a little bit off because they're all healthy Californians. But regardless, when you look at across US, it's pretty consistent in terms of validating. So in summary, the risk prediction is pretty excellent. 10-year, 30-year estimate for total CVD, for ASCVD, as well as for heart failure. It includes kidney function in addition to the traditional risk factor for heart disease. And the optional equation acknowledges the role of social determinants, which we all know is incredibly important for outcome. And of course, it's much, much better than our previous pool cohort equation. So why did the decision threshold change? Because we used to, if you look at the pool cohort versus the new Prevent, you think like we're treating much, much lower risk patients. Well, I just showed you the pool cohort equation overestimated. So the rationale for the new threshold is that the net benefit threshold for moderate intensity is seen even at low as 3% 10-year event rate. The estimate from a contemporary Prevent ASCVD is actually 40 to 50% lower than the pool cohort equation. So that's why you see that 3% risk as really, or greater than or equal to 3% risk as the threshold for starting to think about getting a calcium score, or starting on a statin therapy. So the way we want you to think about calculating or predicting or putting patients on statin is to calculate their ASCVD score, personalize it based on their risk enhancers, and then, of course, reassess depending on, when you did the equation, when because patients age throughout. When you started at 40 or 45 or 50, you're going to continue to reassess patients and then decide to treat. So let's just go through this algorithm here. So you're going to estimate the risk, the 10-year risk. If they're low risk, 0 to 3%, you're going to congratulate them, and you're going to say, continue your diet and risk factor modification. If they're borderline risk, 3 to 5%, you're going to discuss the risk estimate and therapy, and you're going to do the risk enhancers, which we'll talk about. If there's clinical uncertainty, you're going to think about getting a calcium score. We are a very big proponent of calcium score, especially in this guideline. Not so much for the clinician, but I think for the patients too, because patients love to, I think, see that number, sort of get their guidance from there. And then, of course, depending on what it shows, to start therapy to guide on the level of LDL control. Intermediate risk, you're going to start treatment. If there's clinical or patient uncertainty, calcium score to revise and modify. And then, of course, start therapy. If they're high risk, there's no need for a calcium score. There's no need. You're going to start therapy. So these are the risk enhancers. So you all know about this, the family history, siblings or parents less than 55 years of age. If they're male, less than 65 for a female. The higher risk ancestry, we all knew about Southeast Asians. Filipinos make it into this guideline. They have a very, very high risk. And then if you're gonna get it, we're not saying you should get it, but if you got it, the high polygenic risk score. The reason for the polygenic risk score having that sort of a 2B guidance is because polygenic risk score is really validated in Caucasians. It's really not that accurate in Hispanics. It may be in the future with more data points, or Asians or Blacks. And that's the reason for the lukewarm embrace of the polygenic risk score. The clinical condition, we all know about the chronic inflammatory disease, lupus, inflammatory arthritis, psoriasis, CKM syndrome, the kidney syndrome, kidney metabolic syndrome, and then the reproductive risk markers, early menopause, less than 45, preeclampsia, gestational diabetes, adverse pregnancy outcomes, and then biomarkers, hsCRP greater than 2 on more than one measurement, elevated triglyceride greater than 150, persistently elevated LDL or non-HDL or ApoB, and Lp(a) greater than 125 nanomoles per liter or 50 milligrams per deciliter. We're very, very proud to say goals are back, because my God, what does it mean to lower somebody by 50%, which was in the 2018 guidelines? Nobody knows. I certainly don't know. And so I think the goals are super important. So for borderline risk, so 3 to 5% or 5% to 10%, you have all these other things, diabetes, calcium score. Calcium score, I want you to understand, even though it's written like this, it is really 75%. If you are 40 years old and your calcium score is 1, your LDL is not less than 100. That's not your goal. Your LDL goal is actually less than 70, because what that should actually say is calcium score 1 to 99 or greater than 75% for your age. It really should be age matched. High risk, type 2 diabetes with risk factor, heterozygous FH, calcium score greater than 75% for your age or greater than 100. And then ASCVD for very high risk, calcium score greater than 1,000. So along with the LDL goal is a non-HDL goal, and making its appearance, yay, in the guideline is apolipoprotein B. We like the LDL and ApoB goals here, especially as you get into a higher risk, especially for diabetics and metabolic syndrome patients where there is discordance of LDL and ApoB. So for high risk, LDL of less than 70, ApoB less than 70, very high risk, LDL less than 55, and ApoB less than 55. So as we talked about, calcium score is super important in this guideline to be the risk adjudicator, but also to sort of guide our patients, because oftentimes patients are very reluctant because they see on the internet that statins kill, or statins destroy memory, or statins cause cancer, all these nonsensical things that are out there, along with anti-vaccination nonsense propaganda. So we like calcium score. So calcium score really based on numbers, but also based on the 75th percentile for your age. Because if you are 40 years old, your calcium score should not be even, it should be 0. I'm so glad about that blue banner, right? God bless. How many of those blue banners we get every day? The importance of incidental coronary calcium. A lot of our patients are getting lung screening, and you see the incidental calcium. And I don't know if you've seen it recently at the Cleveland Clinic, but there's an AI now background of the CT chest for lung screening that gives you a calcium score. Have you guys seen that? Yeah. And based on that, I think you can use that to sort of modify risk and get the LDL goal. Now, this is we're all among friends, so we're just going to say it out. Where do you see the first calcification? In the coronaries or in the peripherals? I'm going to ask the fellows over here. No judgment. Peripherals or the coronaries? Where do you think you see your first sign of calcification? Yes, in the peripherals. Yeah. Crickets over here, crickets. In the peripherals, you rarely see it in the coronaries first. It's always in the peripheral arteries. And so when you see abdominal CT, oftentimes you see it there at the very first. So for diabetes, this is the place where we actually have differing guidance between the ADA and the ACC/AHA guidelines. For ADA, all diabetics, regardless of anything, their LDL goal is less than 70. If they're high risk, if they have ASCVD, it's less than 55. It's different for the ACC/AHA guideline. If they have no diabetes-specific risk markers, we say LDL goal is less than 100. If they have these risk modifiers like long duration, albuminuria, retinopathy, neuropathy, ABI, then it should be less than 70. I personally think lower is better. And I personally think that, that yes, it's great to have LDL less than 100, but if I was a diabetic, I would want my LDL to be less than 70. My favorite guidance is measuring LPA once in all adults. And I think this is super important and super relevant regardless of what we find in the LPA trials that will be coming out this year and next year. Measuring LPA, I think, is super important because it really does increase the risk. LPA is a causal risk factor. Again, that's a causal risk factor for heart attack, ASCVD, calcific aortic stenosis, stroke, and MI. It's a causal risk factor. So if you're greater than 50 milligrams per deciliter or greater than 125 milligrams nanomoles per liter, it increases your risk by 1.4-fold. If you're greater than 250 or 100, 2-point-fold increase. If you are greater than 430 or greater than 180 milligrams per deciliter, it increases it by 4-fold. There's a lot of debate about people are like, why do you check it if you can't lower LPA? Well, there's actually very good data that if you if you have patients with high LPA, but you get their LDL down to less than 70, you treat their hypertension, you put them on aspirin, they actually do better. Their risk is not zero, it's not the same, but you really tremendously lower their risk for ASCVD. So you have high LPA. Let's say it's greater than 125, and I think that's really the cutoff, 125 nanomoles per liter or 50 milligrams per deciliter. If you have that, you want to control everything you can. Blood pressure, diabetes, weight, all this stuff. Lipids, you want to control it as tight as you can. And if you have ASCVD, you want to try to get them to super low goals. You want to get their LDL down to less than 55. And this is when you're going to add on therapy to get them to that goal. So how do we do it at the Cleveland Clinic? Well, we first measure it, which is fantastic. And we use lower goals. So if you're primary prevention and if you have high LP little a, we get your LDL down to less than 70. If you have high LPA and you have ASCVD and you never had a heart attack, we still get you down to less than 55. We start with statins, and then depending on what you need, we add therapy to PCSK9, Zetia, bempedoic acid, or bempedoic acid plus Zetia. And then with a very high LP little a, regardless of, obviously secondary prevention, they're going to be on aspirin, but we start aspirin therapy on primary prevention. And the data, I'll show you the data in a second. But why is there such a focus on LPA? Forgetting the fact that now there is 3 different compounds that lower LPA drastically. There's very good data, as I told you, that if your LP little a is high, so if your LP little a is 75 milligrams or 110 milligrams or 175 milligrams or whatever, it actually is almost similar to having homozygous FH. That's the reason why it's so important to measure and to treat the other risk factors. There's a lot of nonsense out there about PCSK9s lowering LP little a. And so it for sure does. The absolute change in LP little a, you can see here, 36 nanomoles per liter. But the median change is not that impressive. So if your LP little a is like 250 nanomoles per liter, getting your LP little a down by 16%, I don't know, right? Is that what's driving it? Well, certainly there is some data that if you have higher LP little a quartiles, that you benefit from being on PCSK9. But that's because I think you lower that LDL, you drive down that LDL so aggressively. That's the benefit. And we will know in very, very short time whether in the era of high-intensity statin and PCSK9, whether lowering Lp(a) really matters, because that's what LPA Horizon, Oceana, Acclaim will tell us. The data about aspirin's pretty interesting and very convincing. This is the ASPRI trial. This is aspirin in older adults. This is in Australia without ASCVD. And they asked the question, does aspirin help? Does aspirin not help? And in the overall study, aspirin did not help. Aspirin lowered, events, but made you bleed a ton. Except in people with genotype that increases Lp(a). In that patient population, there was a bleeding risk, but look at the MACE benefit here. Similarly, in the Women's Health Initiative, this is a women's health study looking at postmenopausal women greater than the age of 50, whatever, with postmenopause, carrier versus non-carrier. You can see that people who have the genotype for having very high Lp(a), they benefited greatly from the reduction of stroke and heart attack, with the bleeding risk that was pretty comparable. Number 7 is managing special population. So CKD, stage 3 to 4, regardless of the age, HIV, age greater than 40, regardless of LDL, regardless of their LDL. We want them to start on statin therapy if their LDL is greater than 70. If they have cancer, to continue lipid-lowering therapy unless contraindicated. Consider statin, especially if you're going to for the anthracycline cardiotoxicity. That's 2B. The reason for the HIV comes from the trial REPRIEVE. This is pitavastatin versus placebo, 7,700 patients with HIV on ART, and looking at overall reduction in MACE. And these are people with not very high LDL. And this is the reason why LDL, if we want to start statin therapy, if their LDL is greater than 70 milligrams per deciliter. Treatment during pregnancy and lactation, the guidance is still, if you are lactating, you are not going to do statin therapy. People with childbearing age with very, very high cholesterol, you're gonna have one-to-one discussion. But if they're not at very high risk, then you're gonna stop the statin 1 to 2 months before attempting to get pregnant. And you're not gonna do statin therapy throughout pregnancy. Now, there is kind of an interesting statin called pravastatin. Pravastatin actually decreases preeclampsia. And so there are studies that have shown that it's safe to do pravastatin during pregnancy. And for our homozygous FH patients, we tend to put them on pravastatin throughout pregnancy. Hypertriglyceridemia, the number one cause of high triglyceride in America is diet. Exactly, it's diet. It's diet, obesity, things like this. And so we're gonna start with lifestyle therapy first, because obviously weight loss, exercise really helps. You wanna talk to them about sugar, wine, pop, all this stuff. And then of course, total fat reduction, avoiding alcohol, and really avoiding carbs and things like this. So, there's a lot of data out there about triglycerides, some of it not good, some of it good. We'll go through that data in a second. But for majority of your patients, really you can control by controlling diet. So when do you start treatment for triglyceride? Well, if they have increased ASCVD risk, you're gonna start with statins first. You're gonna use non-HDL and ApoB Gold to guide therapy. When you're gonna do treatment for high triglyceride is when you start to have increased risk for pancreatitis. Omega-3 fatty acid, there's a lot of controversy out there. Strength versus reduce it. One is pure EPA, the other one is DHA, EPA, all the stuff. There's lots and lots of controversy. but the data is pretty clear about statins being the first line of therapy for ASCVD. If you're worried about pancreatitis risk, you're going to start fibrate or omega-3 fatty acid. And if they have FC, you are going to then do olezarsen. Now, people who needs olezarsen or plozarsen or whatever, they should really come to preventive cardiology clinic. Not because we need to diagnose them, but also because you don't want to be filling out the 18-page paperwork to get these people started on these therapies. Now, goal number 9 is for people with established ASCVD. Very high risk. That's 2 major ASCVD events like ACS, history of MI, ischemic stroke, PAD, or 1 major ASCVD event plus 2 high-risk factors, age greater than 65, whether you've had PCI, they're a smoker, diabetic, heart failure, hypertension, LDL greater than 100, they're going to have their LDL less than 55. Everybody else, if they have had 1 PCI, all sort of stable, the goal is less than 70. Now, that was before Vesalius came out, because the guidelines actually were written before Vesalius came out. The Vesalius is a stable patient, high risk for cardiovascular events, but no prior MI or stroke, LDL greater than 90 or ApoB greater than 80, and at least one of the following. CAD without MI, CVD without stroke, PAD, high-risk diabetes, and then follow them up for 3-point MACE, 4-point MACE, evolocumab versus placebo. And this is what they found. They found that, placebo around 100, some of us have been complaining about the fact that Vesalius should have gotten their LDL down to less than 70. Regardless, the evolocumab, the LDL treatment was 45. And of course, there was a great event reduction with Vesalius. Regardless of whether you look at 3-point MACE or 4-point MACE or key secondary endpoint, everything going in the right direction. So what does this tell me? Well, this tells me that for most people, their LDL should be less than 55. So this 70 or whatever, I don't know. Based on Vesalius, I think in a perfect world, when you get diagnosed with ASCVD, I think your LDL should be less than 55. LDL is like no other thing in medicine. So in medicine, if your blood pressure is too high, that's bad. If your blood pressure is too low, that's bad, giving you that J-point curve. Same thing with glucose. Too high is bad and too low is bad, but not with LDL. There is no point in which LDL is too low. That's dangerous. LDL does not have a J-point. LDL is not a U-shaped curve. So I think lower is better. If I have ASCVD, I would want my LDL to be less than 55. So how are we going to get there? Well, we're very lucky to live in an era where we have 1,000 things, literally, that helps us. Whether we work on the whole citrate, ATP, HMG-CoA reductase pathway, whether we work on the intestinal uptake pathway, whether we work on the PCSK9 pathway, really, we have an amazing armamentarium to get us there. So let's just talk about statins. Been around since 1980s. Everybody in this side of the room, they weren't even born in the 1980s. Been around since 1980. Doesn't cause cancer, doesn't cause dementia, reduces your risk for heart attacks, makes you live longer if you've had a heart attack and stroke. Been around forever. It's an amazing drug. Zetia lowers LDL by around 15 to 20%. Been around since 2002. Reduction with Improve-It, 7% MACE reduction. Evolocumab, alirocumab, which is monoclonal antibody, lowers LDL around 50 to 60%, improves ASCVD outcomes. You take it every 2 weeks or monthly. And then, of course, we have now bempedoic acid. It's an ACL inhibitor, works 2 steps above HMG-CoA reductase, reduces LDL around 20%, combination therapy with bempedoic acid plus Zetia around 35 to 40% reduction. It does improve ASCVD. The only caveat is you have to be careful about gout. Check uric acid before. And then, of course, we have inclisiran. It's a siRNA, lowers LDL by 50%. It's a much If I had to do a head-to-head comparison between a monoclonal versus siRNA, monoclonals win every time because they lower it much more effectively, but does have 50% reduction. Outcomes trials ongoing. And then, of course, as of 3 weeks ago, we now have the oral PCSK9 inhibitor. Oral PCSK9 inhibitor is like a Synthroid. You can't eat after you take it. Your stomach has to be empty when you take it, but it does lower LDL by around 60%, which is pretty amazing. And hopefully it will be on the market. Hopefully it will be way cheaper and will be somewhere close to the bempedoic acid price point, which will put into which would be very interesting for these injectable. As you know, some of these PCSK9 inhibitors or monoclonal antibodies have an anti-drug antibody that some people get. Some people get a lot of UTI from it. And so it will be it's a great time actually to treat patients for cholesterol. So now we have some time to go through some case studies. I was thinking we would go through some case studies and then open it up to questions, or we can open it up to questions and then go through case studies. What do you think? What should we do first? Case studies? All right, case studies. Here we go. All right. 47-year-old woman presents to your clinic for worsening cholesterol. She's got really nothing. She has a family history, father with MI, paternal uncle, mother has high, cholesterol. She's on a Mediterranean diet, she exercises. She's on nothing. Blood pressure's great, BMI's a little chunky. Her total cholesterol is 233, HDL's 42, triglycerides 95, LDL's 172. EGFR is normal. Her 10-year ASCVD is 1.8%, 30-year is 10%. So based on the guidelines, what should we do? Well, based on the guidelines, it says if your LDL is greater than 160 and you're greater than 30 years of age, you should be on some therapy. So you should be on some moderate therapy. If you agree or disagree? What do you think? The audience, what do you think? 47 years old, LDL is 172. Let's say she says to you, oh my God, you are trying to kill me by giving me statins. I would like to try diet and exercise. What is the length of time you should do to see if the diet thing works? Yeah, it's around 6 months. And how much, and there are people who are hyperabsorbers of cholesterol from their small intestine. So that makes about 15% of the population are hyperabsorbers. So if you go hardcore vegan, let's say she's a hyperabsorber, she goes hardcore vegan, and we can see a dramatic reduction in her LDL in about 6 months. But for most of us, we are moderate absorbers. So even if you go vegan, you may not see the kind of reduction you want. You may only see like a 20% reduction. 20% reduction of 172 is still pretty high. Now, when you start statin, when should you get your next cholesterol testing? 8 weeks? 12 weeks? 6 months? What do you think? It's around 8 weeks. 8 weeks. In trials, we do 6 to 8 weeks, because that's when you can see it. This notion of 12 weeks is because of EPIC, and you can do 2 weeks, 2 months follow-up, 3 months follow-up, and we all want to do 3 months follow-up. There's no magic to 3 months. It is actually 8 weeks. Okay, next case. 62-year-old male. This is actually a real patient of mine. PCI of RCA, 95% stenosis, remote tobacco, like remote. 80 milligrams of torvastatin was started. Baseline LDL is 107. Upset because they're like, what the heck? My LDL is 107. How come I got ASCVD? No idea. So LDL-C on 80 of atorva is 62 milligrams per deciliter, which is a 42% reduction. What should we do here? We're happy here? No, we're not happy here. We're not happy here because obviously for this man, LDL 107 actually caused stenosis, so we're not happy there. So we actually do recommend greater than 50% reduction here. Now he is, this sort of ASCVD major, but he doesn't fit these high-risk condition. But based on Vasilia's, he actually should have his LDL much, much lowered. And so we actually put him on ezetimibe in addition to Lipitor 80, which then got him down. We won't go through this very, very small slide here. And then this is the ASCVD continuum. Now let's go through this one. 52-year-old female, diabetes, 12 years, gestational diabetes, with 1 out of 2 pregnancy, hypertension, mother with diabetes, father who has COPD and smokes. She's on Jardiance, semaglutide, lisinopril, atorvastatin. She exercises, her blood pressure is 128/76, BMI, she's quite thin, 21. Her A1C is 7.2, so not that well controlled. LDL is 103, ApoB is 126, so she's discordant, LDL versus ApoB. Her Lp(a) is less than 7. So her risk estimate, 10-year is 6, 30-year is 23.4. And she's on 10 of atorvastatin. What do you think her goal should be? She's 103 on 10 of atorva. 70, yeah. She should be less than 70. She's got multiple risk factors. She's got she's got tons of risk factors. Her ASCVD risk score is high. So after she gets started on 40, so her LDL is 85, ApoB is 96. Are you happy? How much does Lipitor from 10 to 20 give you in terms of LDL reduction? Yeah, 6 to 7%, 7% reduction. So 20 to 40 gives you another 7% reduction. Congratulations, now you've gotten 14% reduction. Okay, but your ApoB is still 96. Your LDL is 75. She should really be at an LDL of less than 70, right? So she actually should be on a much more potent therapy. So you're gonna go to Lipitor 80? No, you're gonna probably add a non-statin at this point, right? You're not gonna go to Lipitor 80. You're gonna add a non-statin at this point. Okay, 5080, Abhijit actually wrote a fantastic paper for Cleveland Clinic Journal of Medicine, where he wrote about when do you start Zetia or bempedoic acid plus Zetia, and when do you start a PCSK9. And his sort of guidance is that if you want an LDL greater than 50% reduction from your baseline statin, then you're gonna do PCSK9. You're gonna forget about the bempedoic acid plus Zetia, blah, blah, blah. You're gonna go to just PCSK9. But if you're looking for like a 30% reduction, you can go to bempedoic acid plus Zetia, or you can go to Zetia alone. I think that's a very sort of simple tool. You want 50% reduction, you go to a PCSK9. You want 30% reduction, you go to Zetia plus bempedoic acid or Zetia alone. And then you see if you need to add bempedoic acid. Okay, 80-year-old guy, self-referred for cardiovascular evaluation, blood pressure's high, smokes tobacco, terrible, and then has high cholesterol, father with life-threatening AFib at the age of 76, exactly. Ask your doctor if early ablation and Watchman is right for you. And then mother with breast cancer, truck driver, on no medication. He's very, very resistant due to any potential perceived impact on his professional licensure. BMI is 27, blood pressure is 136/84, his LDL is 142, and everything else is normal, including Lp(a). His risk is high, doesn't really want to start medicine. Yeah, exactly. I like the calcium score. I mean, by guidance, he should be on therapy. Absolutely, he should be on therapy. But of course, we live in a real world. People don't want to take medicine. And I think that's okay. I think calcium score here is class 1. And there is a big difference if his calcium score is 0 versus calcium score of 359. If his calcium score is 0 and his LDL is 140, we can say, okay, you try your vegan diet, your diet and exercise, and let's see what your LDL is. But if your calcium score is 359, he will agree with you, right? To start therapy, because I think that makes a huge difference in how we treat, how aggressively we treat, but also the patient's perception of urgency for starting treatment. So of course, if you have the guidance for calcium score versus 359 is very, very different. And then that's the guidance here. And I think this is my last case. 36-year-old female, OBGYN, severe high cholesterol, father with hypertension, mother with high cholesterol, maternal brothers and sisters all have high cholesterol. Brother had angina and PCI. And then this is her LDL. LP little a is 47, LDL-C is 246. She's only 36. Start med or don't start med? Yeah, you want to start med. What else you want to do here? You want to probably get genetic testing here. And the genetic testing here is super important because most likely she's going to need statins, but she's going to need a lot of stuff down the line. And it'll be very easy with the genetic testing to actually get drugs, like the PCSK9 drugs. And I think, and also there's a huge difference in terms of outcome between patients who are genetically positive and genetically negative. And if you're genetically positive, you actually treat them to a lower goal. Let's say she has genetic testing and her LDL, then her genetic testing and her genetic testing is negative. Her LDL goal is around 100. But if her genetic testing is positive for LDL receptor defect, whatever, then her LDL goal is less than 70 because those people with genetic defect, they go on to have much more, they go on to have many more events than people who are not genetically positive. I think that we can stop here and then leave the rest for questions. Thank you for your attention.
Person is ostensibly asymptomatic, but it's time to do something more beyond statin and bempedoic and this and that.
Well, if they get a calcium score and if it's greater than 400, I usually start with a stress test, rightly or wrongly. I start with the stress test. And mainly it's, I think it's important for patients, psychological safety, to start with a statin. If they're greater than 1,000, if their LDL is greater than 1,000, if their calcium score is greater than 1,000, I do a stress test, but I have low likelihood to cath someone. Like I want to cath them and see their arteries.
So yeah, like we've discussed, we look at the images and if there's a lot of plaque in the left main, LAD, etc.
Yeah, I think
Questions?
So Dr. Nissen, through his wonderful IVUS work, when you look at the totality of data, there is plaque stabilization at LDL around less than 70, but plaque regression if you get an LDL less than 55. So that's the reason for the sort of the enthusiasm for less than 55. And when we explain it to patients, the hardening of the artery, the calcification is not the enemy. It's everything behind that calcification. It's the lipid core, right? And the lipid core appears to get smaller when you have significant calcification. So you see a lot of data out there with Clearly and HeartFlow where they're measuring the lipid behind the plaque. I don't know if that data will ever come to be something or not, but the IVUS data, which is the best data to date, shows LDL less than 55.
Osama.
So genetic therapy, there are gene testing going on for PCSK9 as well as Lp(a). As you know, when people get gene therapy, Dr. Desai and I have actually unfortunately, a lot of experience with this. They're like immunosuppressed on high dose steroids. This is not for the faint of heart. This is truly not for the faint of heart. And I think, eventually maybe it will happen, but I think for the majority of population, I still think statins are the best and the statins will be around forever. Yeah.
So questions, Sagar?
So if your calcium score is 0 and you are like, I cannot start no statin therapy. Then we get a calcium score in 3 to 5 years, 3 to 5 years. But if you have a high calcium score, do not get another calcium score unless you want to like make yourself nervous and, you know, make everyone nervous and drive everyone crazy. Do not get another calcium score. There is actually an article from Amit Kara at UT Southwestern talking about the delta change of calcium and whether that has an impact. It may, but please don't get it because I'm going to treat you as if your LDL is really high. And then the one last thing is that oftentimes you see elite athletes or people who exercise super aggressively. Like they run 58 marathons. They are, you know, not weekend warrior, they're everyday warrior. And their calcium score is quite high. And that's actually a body of literature that's super fascinating. And the thought is that because of the chronic stress and the constant sort of demand and oxidative stress or whatnot, that increases calcium. And those people also should be on cholesterol-lowering medicine.
So, Leslie, if you were to predict the future now with the availability of oral PCSK9, the next iteration of guidelines, how do you see the workflow of starting lipid-lowering therapy evolve? Obviously, statins will be still the first line, but do you think everything else will be replaced by the oral PCSK9?
I think the oral PCSK9, hopefully it will go to, you know, there has never been a study that lowers LDL dramatically that's been negative. So if you look at every trial known, apparently you can now bet on trials, on Kelsey or whatever this nonsense is.
Eric?
Yeah, but if you lower LDL, there's never been a trial that dramatically lowers LDL that has been negative. So unless there is some untoward secondary side effect of the oral PCSK9, it should be a positive trial. And if it's a positive trial, it's going to be a blockbuster for Merck. Yeah, I mean, I think here's the thing is I see a lot of people who have been touched by you guys, you know, with first cabbage, second cabbage, third cabbage, and lots of people with PCIs. But a lot of people we see are people who are worried well, and they don't understand this ApoB, lipoprotein little a, LDL, my calcium score, what the heck? And there is sort of this confusion out there. So we're happy to see all and any of your friends. So first of all, I just give them a number, and it's $14,000 a year. And the $14,000 a year is actually the cost of PCSK9 out of pocket. And so if you have $14,000 a year, please to go on them. But what I tell them actually is a couple of things. One is PCSK9 does not lower inflammation, has never lowered CRP. Statins lower inflammation. It has all these other really good benefits like angiogenesis. We think, you know, there's a reason why statins are used in PAD because it creates blood vessels. It also lowers inflammation. PCSK9s do not do that. They're great, but they actually don't have all these other beneficial effects. So I say, listen, let's try PCSK9. So you'll see my patients, even when they're on PCSK9, they're on statins, even if they're on once-a-week statins. If you're going to do once-a-week statin, please do rosuvastatin because the half-life is 36 hours, unlike the other statins.
Any other questions? One last question. You mentioned inflammation. There was a recent announcement of a trial that
Zeus.
Zeus is angry, is what
Yeah.
the title said. So what are your thoughts about that?
So Zeus was a study of IL-6 inhibition, which is an inflammation. And as you know, CANTOS, which is canakinumab, was extremely positive. So why didn't Zeus work? Now, Zeus didn't work, I think, personally, because they picked a population that was already gone, already done, already well into their disease. And that's the kidney disease population. And that nothing has ever worked in the kidney disease population. Statins don't work in dialysis patients. They work in people with CKD stage 3, you know, and 4, but not in stage 5. And I think the IL-6 may be too late. You need to, or IL-6 that was studied, I think you need to do it earlier in the chain. I think not just in the inflammation chain, but also in the patient. you want to start them on early. The true patient you want to start inflammation study on is the guy who came in with ACS and you start them on statins and you start them on an inflammation drug. And that's what CANTOS was, MI, 3 months to 10 years, and you start them on canakinumab, and then you follow them.
Perfect. Thank you so much. This was absolutely wonderful, and thanks to all for attending.
Thank you.